So I'm a board certified psychiatrist, and in this video, I'm going to break down the difference between textbook psychiatry versus real life psychiatry. This is a question that comes up all the time in my PMHNP coaching academy, where students will ask questions like, can I do this, or is this acceptable? And while these things may not be acceptable on textbook, on paper, in real life application of psychiatry, it takes on a different story. And so here I'm going to break down some of those examples of where real life psych differs from what you're supposed to do in the textbook. So one of the most common examples is FDA approvals. So here for textbook, for example, I'll write FDA approved versus here FDA off-label. So what does this mean? For example, when we use clonidine and guanfacine, those are FDA approved to treat blood pressure. They are not FDA approved for ADHD hyperactivity, but that's a very common practice to use them for off-label uses. Similarly, Wellbutrin, it's approved for major depressive disorder. It's not as approved for binge eating, but we can still utilize Wellbutrin for binge eating purposes. A lot of the SSRIs may not be approved for generalized anxiety disorder or PTSD, whereas some are. But we know that we can still use all the SSRIs for GAD, and we can use them for PTSDs. Even some of the newer ones like Vibrator or Vilazodone can be used for PTSD and GAD, even though the FDA approval may not state that. So this is the nuance here. All an FDA approval means is that the drug company sought out clinical approval by the FDA to market their medication under that thing. Like, that's it. So basically they did studies that showed that, hey, this SSRI is approved for depression. And once they got that approval, they're like, okay, we're set. We're going to advertise this. So they may not have sought out the FDA approval for anxiety. And then like post-release studies will show that, okay, this medication is still helpful for anxiety, but it was only received the official approval for depression, and it's not worth the company's time or money to seek out that additional approval. So that's what you might notice, that FDA approvals come out like 15, 20 years apart, because if the company is able to find a new approval for the same medication, then they can remarket that and continue using that as a brand instead of having to revert to a generic. So and what this leads to is FDA dosing. So FDA dosing limit versus here, you can go higher than the FDA limit. So what does this mean? SSRIs, for example, like the FDA limit for major depressive disorder, Prozac is 60 milligrams. For Zoloft, 200 milligrams. However, in certain scenarios, we can actually go higher than that because there's clinical evidence that going higher can help treat things. So Prozac can go up to 80 milligrams for OCD. Zoloft, we can go up to 250, even 300 sometimes for OCD. Venlafaxine usually goes up to 225 milligrams for the XR, but you can go up to 300 milligrams in select cases. Vyvanse, FDA max is 70 milligrams for ADHD, but you can go up to 80 and 90 milligrams, so on. So the whole point there is that there's an FDA limit, and then but in real life, you may have to go above this FDA limit. And the reason the FDA limit exists is because it's based off the original dosing studies that they did. So the original studies, they may have only tested Vyvanse up to 70 milligrams. But then real life comes out, and then a lot of people test it out clinically, and they find that, that we can actually go higher and still get a benefit for the patient. In select cases, don't be afraid to go higher than the FDA limit if the situation calls for it. With any medication that you're prescribing, it's always a matter of benefits versus risks. And if the patient you suspect will continue to get benefit while the risks are mitigated as much as possible, then you can justify going higher than the limit. And as long as you document for that, it's a accepted standard thing to do in the field of psychiatry. So next thing I want to get into is long-term medications. So ideally for the textbook, for example, we would say either no or decrease long-term use. So that makes sense. You don't want patients to be on these psychiatric medications long-term, especially things like benzos or stimulant, right? Like that's the textbook thing. However, in real life situations don't always play out that way. Sometimes people may try to get off medications and they can't. Other times they still are experiencing a lot of side effects or a lot of that primary condition like the ADHD or the anxiety. So here, I'll write okay, long-term use. So what does this mean? This means that sometimes if I'm trying to get a patient off of a benzo, they might not be able to get off because they feel their anxiety just gets back so worse. And they're like, okay, I understand that there's long-term dementia risk, but this is complicating my life so much right now, this anxiety, that I'm okay with that and I want to get this treated right now. Fair. Same thing, we're trying to come off an SSRI or maybe needing a stimulant for their long-term work productivity. I have this lawyer client, and every time we try to get him off, his work suffers, and of ADHD medication. And he's busy. He works in a high-demand law firm, taking care of his family. And he says, "You know what? Like I've accepted that I might need to take this for the rest of my life, or at least the rest of my working life, and I am okay with that." So that's what the patient verbalizes. So we understand the risks versus benefits. And for him, he believes that the benefits of this medication outweigh the risks. So I'm like, okay. So that's the whole point here, is that in real life, sometimes you might need to go long-term uses of medication, and that is okay. That's part of the risk-benefit analysis that we do for every patient. So the next thing I want to cover is, so textbook psych, it's algorithm prescribing. For example, patient comes in with a depression, anxiety, you try one SSRI, okay, then the algorithm says, okay, then you try another SSRI, okay, that doesn't work, then you go to an SNRI, okay, then you might augment things. Whereas in real life, you might need to jump around. So what does this mean? For example, let's say the patient comes in, this was a real life case. There was a patient that came in when I was in residency, and they had low energy, low motivation, depression symptoms. And so my attending was like, okay, let's start them on an SSRI. And I was like, I'm thinking maybe we should start Wellbutrin because we can target the low energy and depression. But the attending said that no, we should follow the algorithm. And the algorithm is usually starting with an SSRI first and then adding on Wellbutrin and things as needed. That makes sense. But I felt more strongly that I think Wellbutrin makes more sense because I would rather target those specific symptoms like the low energy and motivation like that. And then same thing with like mirtazapine, for example, that's later down the line. But if the patient has trouble sleeping, their appetite's low, then you could start that off right off the bat. Benzos, for example, you may think that, oh, okay, I wouldn't try a benzo first for anxiety. I would use an SSRI first. And then if they fail like 2 SSRI, then I'll go to a benzo. But in real life, sometimes if it's so severe, if it's like an acute anxiety, if I need to address it now, then I might use a benzo because that's what I need to do in real life. And you can see how this stuff interplays too. For example, if I'm in the hospital taking care of a delirium case or an agitation case, they might say, okay, use clonidine or guanfacine, for example, like for autism agitation, before jumping to an antipsychotic because those are milder. But I might jump straight to the antipsychotic if it's more severe. Or in the delirium case in the hospital, let's say if I'm only using 2.5 milligrams of Haldol, but like I try that and it doesn't work, then I might jump to like go to higher than expected dosing, just because I'm like, okay, I might need to use this. Or I might add on, for example, Haldol and Ativan to treat agitation, as opposed to just trying one. I might do both because I'm doing real life psych prescribing, not just like what an algorithm says. So a lot of times the algorithm, those are just treatment guidelines. Remember that they're not law. They are not rule. They are guidelines based off of just clinical data and clinical experience. However, the real life patient in front of you, that's what ultimately makes that decision. So the next is coming to polypharmacy. So obviously in the textbook situation, you would want no polypharm. So decrease meds, which of course makes sense, right? Every medication can have problems, side effects. And so You want to limit the amount of medication that the patient's on. Like that makes total sense. However, for real life, polypharm is possibility. Some patients may need a whole cocktail of medications. Obviously, you don't want those medications to be non-scientifically sound. Like you don't want their mechanisms to be interacting. Like you don't want to be using multiple antipsychotics or multiple mood stabilizers at low doses, etc. But you may need to have them on a cocktail. For example, I have this autism patient, he's got severe aggression, and he's on Depakote, he's on Risperidone, he's on guanfacine, he's on Vyvanse. Like he's on a big cocktail because that's what he needs to manage. He's a big guy and his agitation aggression can be very dangerous. So that's what he needs. And so ideally, of course, it would be controlled with one medication, but for some people, they might need a whole cocktail. I see this a lot in my prison population. So for a couple of years, I've been doing moonlighting in a prison. And so there, the patients are so aggressive that they might need to be on 2 antipsychotics plus a mood stabilizer. So that's the thing with real life prescribing it. As you get more experience in the real life world, in the psychiatric field, you'll start to understand this and you'll see cases where sticking to a absolutely clean low med regimen may not be as effective. So this ties into the other point as well too. So the textbooks would say to do conservative management. So what does this mean? Every test question we get, right? Patient comes in with anxiety and depression. What should you do? Okay, yeah, I should do CBT first, or therapy first. Or they have OCD, you should do the ERP therapy first. Or you should try to do diet and lifestyle, or like those type of interventions first. And that makes sense. That sounds nice and pretty and sweet. However, just like with weight loss, ideally diet, exercise, sleep, like those are the things you do. But Ozempic is $1 billion industry for a reason. Bariatric surgery is another huge industry for a reason, because not every patient wants to do those methods, or those methods may not be appropriate for every patient. So sometimes in real life, you might need to do increase meds, or all right, surgical, but that doesn't really apply to us. Increase meds or pharm management, because some patients, they want the Ozempic. Some patients might need the Ozempic. Some patients might need Ozempic and weight loss, or diet and exercise. Not every patient has the motivation or the cognitive skill set to do the conservative management. Some people need that med boost. So for example, I have this patient who has severe OCD, and so she's already in exposure therapy, exposure response prevention therapy, but she says that she's not able to go through with a lot of those exposures. And so the medication helps to dampen the intensity of those exposures, so that way she can do the conservative management with the therapy. Or in the case of the ADHD patient, they may not be able to regulate their kind of thoughts enough on their own. So that's why they have to do the medication approach for that. So that's the whole point that I'm trying to make, is that for some patients, conservative management is not enough. And so in real life, you may have to be more aggressive in your approach. And the last point I wanted to cover is diagnosis. So in the textbook, there's always a clean diagnosis. So what does this mean? Okay, this means, okay, the patient either has depression, anxiety, or they might have PTSD, or they have BPD, borderline personality, or whatever it is. But it's like the diagnosis is very kind of clear cut, ideally. However, in real life, I'll write blended diagnoses. So anyone who's worked with patients can tell you that, okay, the patient might have a little bit of PTSD here and a little bit of ADHD and some depression, and then there's like some personality disorder that's thrown in. So diagnoses in real life are way more messy. A patient comes in with psychotic symptoms. Okay, are those from schizophrenia? Are those like a manifestation of this depression? Are those delusional disorder? If they have concentration problems, is it from ADHD? Is it PTSD related? Is it depression related? Is it anxiety related? they can't sleep. Okay, like, is this just a primary insomnia? Is this related to a lot of their anxiety at night that they can't sleep? Is this more of a PTSD thing? Are they having dissociation? Okay, is this just dissociation as like a defense mechanism from anxiety? Or is this related to more like severe PTSD? Or is this just a pure DPDR? Point being is that the diagnoses in real life are a lot more messy. And then a secondary point is that some diagnoses are there. Actually, I'll make this as a secondary point too. Stigma with diagnoses. So what does this mean? So I've noticed that in a lot of psychiatry practices, there's some diagnoses we hesitate to make more than others. It's easy to throw on depression, anxiety, ADHD labels to people, but now saying that some kid has conduct disorder is kind of a jump. And the patient may not receive that properly, and that might cause problems for the patient or the family. And I ran into this issue personally where I diagnosed a kid with conduct disorder, and then now the kid had trouble getting into like a new school system because that diagnosis was on their record. And now the patient was yelling at me, and it created a whole kind of problem with the clinic because they were like, because now the patient was saying how dissatisfied they were with their experience there. Well, I was like, okay, should I have diagnosed conduct disorder? Should I not have? Because the problem could have ran the other way too, where you do more of the conservative diagnosis, which is the ADHD. But then if the kid is still having such severe behavioral problems that they reach the level of conduct, now am I negligent as a doctor for not diagnosing that? Point being is that these are the kind of dilemmas you run into in real life. Or if I diagnose with BPD, borderline personality, that's kind of different than just saying, oh, you have some anxiety problems. And a lot of people are hesitant to do that. They don't want to have that stigma, or they don't want the patient to feel like they were diagnosed with this thing. So that's where the difference really comes in here. And that doesn't really exist in the textbook diagnosis, but in real life. So we may hesitate to diagnose some things that we know we should be diagnosing because of the stigma or how the patient will perceive it, or we don't want to cause anger or trauma within the patient. And quite frankly, we're just not sure because diagnoses are in flux. It's not like, okay, your A1C is 6.2, you have diabetes. Diabetes, the diagnoses are even sure. So that's even another point that I can add. All right. I think that could apply here, blended diagnoses. Unclear. Diagnoses are unclear in psychiatry. They're not always clear, and thus a lot of times we use what's called a working diagnosis, meaning that this is the diagnosis that we have at the time that we're going off of, but things can change later down the line. A common example of this, like not wanting to diagnose things, I've seen in the inpatient unit where the patient might have BPD features, but they get diagnosed as bipolar because the insurance will pay for bipolar hospitalization, but they won't pay for a BPD hospitalization. So that's the difference. But yeah, this is covering some of the main key differences I've seen between textbook psychiatry versus real world psychiatry. If you're a provider, you're gonna encounter some of these no matter what. So definitely stay accounted for this. And if you want to learn how to really do real world psychiatry treatment, real world psychiatry practicing, the stuff that they don't teach you in school, you want to learn from a board certified child, adolescent, and adult psychiatrist, meaning I've done psychiatric residency and child and adolescent fellowship. The best place to do that as a PMHNP is in our coaching program, where we've had over 230 students go through so far and really level up their real world psych prescribing skills. So definitely check that out, and I'll see you in the next video.